Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of soft tissue sarcoma, part 1. Dr. Travis Brown, as we go through this medical life, there are certain conditions and diseases that just sound sinister. Sarcoma is one that hits my layperson's ear oddly. I don't really want it, do I?
No. This is fortunately, it's a rare condition. But yeah, sarcoma is one of those ones that you actually kind of need to have almost studied medicine to know what it is, what it means. Now, it sounds bad, and it is bad in a lot of cases. And sarcoma is one of those ones that is what we call malignant soft tissue. And so soft tissue feels into this weird area. We often talk about epithelium. This is cells that are constantly dividing. This is mucosa. This is skin that normally has normal turnover. And so it's constantly dividing. So when errors end up building into cells like that, they're dividing all the time. You can accept that, because it's dividing all the time, some error may occur, and you get something like a skin cancer, which people are far more familiar with. The challenge with sarcoma, it's connective tissue. So particularly when we're talking about soft tissue, we're talking about things like muscle and ground tissue. You've got all the things that we call like ground substance, which is the stuff in between, like joints and
tendons.
Yeah, with tendons to a point, yes. And so all those soft tissues. Now they're not typically dividing; they're actually dormant most of the time. And to get something that is a malignant dividing is actually quite hard when you think about some tissue that's not dividing all of the time. And so, even for doctors, this is a rare malignancy. For pathologists, it's still rare. I have hardly seen any in my time sort of practicing. And so this is when you're studying it, you're actually having to go to like a lot of libraries, slide collections to actually see these because they're not common and they can be very difficult to treat. And so this is the combination of, well, July is Sarcoma Awareness, and so we're actually putting this series together with Fiona McLean, who's been absolutely instrumental in helping us get all the guests for this one, as well as the Australian and New Zealand Sarcoma Association. And so this is actually getting doctors, sometimes even patients, to be aware of this condition, to go in a deep dive and say, hey, let's discuss this, because sarcoma is a very broad term. So you can have liposarcoma, leiomyosarcoma, you can have a whole range of sarcomas. And the reason why the names is because we name them conventional where we think it is arisen from. So you can have fatty tissue, lipoma, liposarcoma. So you put the sarcoma on the end and it shows it's malignant. And so, look, if you look through the historical records, cancer is always been recognized. We actually, as doctors, even through in ancient times, you recognize cancer, but you get hints of sarcoma from authors and medical writers. So when we look at the ancient Egypt, Eber Papyrus in 1500 BCE, they wrote about fatty tumors. Now that's quite common, fatty tumors, benign fatty tumors. So we do call them lipomas, and people will have this fatty lump, and that's a lipoma. It's benign, can easily be taken out. It's not a problem. And they even noted, you can treat these lipomas surgically. But if it's a large tumor in any part of the limb, they've said, don't remove it. And you couldn't treat it. And so you get this little hint. They must have had some large tumours in the limbs of ancient Egyptians that they recognised this is more sinister. So look at Hippocrates, and he noted that older patients can have these superficial and deep-seated tumours in these arms and thighs. Galen, the great physician, or the great Greek physician, he described these fleshy tumours that had this appearance like raw meat. They called it sarcos. And so you're starting to see, they recognise that there were some unusual tumours about, even in ancient times. Now, they wouldn't have known the difference between that. Most ancient physicians noted, though, that these weird tumours were not well treated. So you could treat them surgically, but it didn't seem to affect them. And so they noted some of these features which were a little bit more sinister. And this was like the irregular shape. They had livid in colour. If it was ulcerated, and if you couldn't move it from your fingers, like if you couldn't push it around, if it was kind of fixed, these were poor signs for these, well, what we would say soft tissue tumours these days. Now, I'm using the word tumour. Tumour just means swelling. And if you look at the actual, most people think, oh, tumour is malignant. No, tumour is just a swelling. It literally is from the Greek word. And so when I say tumour, it can be benign or malignant. So when we say fatty tumour, it's pretty much a benign thing unless we specify liposarcoma. Sarcoma says it's malignant. So
I don't think anyone would mistake the word sarcoma as being benign.
No. And so when you start looking through you start actually going through the ages, you've got Theodoric of Salerno, which is the priest physician in the 13th century. Now, he did note these fatty tumours, but he said if they're dark in colour and really firm to touch, they're cancerous. Now, he said don't treat these. But then you look at Guy de Chauliac, and he was a physician of 3 popes in the 14th century, and he said, yeah, you do treat them, but treat them with a wide excision. And so that's the challenge.
Travis, sorry, I need to interrupt here.
Yeah.
You began this by saying it's very rare.
It is.
And yet, back in the annals of medical history stretching right back to ancient Egypt, they're being talked about in great detail.
Well, no, I wouldn't say great detail. See, there's just been a few thousand years between so you've got hints of it. And again, they didn't really know how to treat it. They're saying, treat it, don't treat it, wide excision. Guy actually mentioned the best way to treat it was to get it early when it's small. But again, you're not quite sure exactly what they're treating because they didn't have the diagnostic criteria that we have. We get to 18th and 19th century, and we actually have surgery, again, still being the best recommendation, but this is no anaesthetic. I mean, you're talking about potentially deep, soft tissue areas. That would be really tough. But the surgeons in the 18th and 19th century started talking about, well, you need to have clear margins. Now, wow. Anyone's guess is actually how do you confirm that they had clear margins? Because they weren't routinely doing microscopy. I wasn't going to a pathologist, are these clear?
I was going to say, a pathologist in you is going, yes, good work.
Excellent. But what does that mean? And effectively, I imagine most surgeons would have gone as soon as I've operated, the margins are clear. And it's just one of those things. Could they get it out fully? They would have known at the time. But still, that was their aim. And we get to the 19th century and microscopy is starting to be done now. And so when they look down to the microscope, they called these lesions fungus hematodes. And so this was often vascular tumours. So these might have been angiosarcomas, but you're not really quite sure. And the surgeon Charles Bell, he was a British surgeon, he wrote a book on surgical observations in 1816, where he talks about soft cancer, but he actually means what we would interpret today as a sarcoma.
Soft cancer may attack any of the structures of the body. It certainly arises in the soft substance of the limbs.
And so he described this soft cancer in liver, in lungs, in eyes. Even one case is surrounding a popliteal nerve. And we would recognise these days as this is classic soft tissue sarcoma region, at least. You have in France, you have Lebert in 1813 to 1878. He did this atlas and microscopy of some sarcomas where he introduced these new terms, rhabdomyosarcoma. Now, that's something that we talk, it's a skeletal muscle malignant tumour. He also talked about an extra abdominal desmoid. So you're starting to get the terminology coming through that would be familiar. This is around the same time that you have Virchow, so he's a pathologist from Berlin. You have Samuel Gross, Samuel Wilkes, all around the world, and they're starting to present these cases of sarcomas, of these soft tissue malignant tumours. and that they're different to carcinomas, which people are much more familiar with. And so this is the time when you start to see the classification, and the classifications and the naming conventions just exponentially grow. And it is confusing. It's confusing for pathologists. We actually sit down and have to study it for years. And even then, most pathologists, when they actually train and get through their exams, don't actually deal in this area. This is a really specialised area for pathologists to go into. And if you see something like this and you think, oh, that's sarcoma territory, you actually often refer it to someone who specialises in this area because it's such a hard diagnosis. And so we come back to, this is the point, sarcoma awareness. If doctors come across it, we want them to be familiar, at least have an educational resource to refer back to, not just for themselves, but for patients. And so this is why we've worked with Fiona and the ANZSA, and to try and get, look, here's a resource, here's further information if they need it, and really just help educate everyone about it.
And if you tell me it's a very rare thing, even for pathologists to see these days, could you have a specimen arrive every time that the sarcoma is possibly there? You would be advised that by the GP or the referring specialist, wouldn't you? Or
not necessarily. That's the thing. You can actually come across, and this is why you're wanting to make sure that, first of all, the GP knows what they're dealing with, sort of flag this. So this is an unusual lesion, and clinically, sometimes it will present unusually, and doctors, GPs may have never come across this lesion after even 10 years. Like, oh, this is a bit unusual. Not only that, pathologists have to recognise that this is something unusual that they're looking at, because we will see routine things routinely, as you know, and you'll get a slide that come across and go, this is unusual, and it has to be flagged by the pathologist. This is unusual. Something odd has gone on here, and they can be very subtle sometimes, which is why you get the specialists in to say, oh, and the specialist can look at it, and this is why we're sort of wanting to encourage, as we will discuss it here, probably more referrals than not for people, because the impact on the patient can be 5, 10, 20 years down the track if it is mismanaged or if it is misdiagnosed, and that can have a real impact on patients.
And that's why you have the ancient Egyptian papyrus by your bedside table, isn't it?
Absolutely.
Associate Professor Richard Boyle is a Sydney-based orthopaedic oncologist and surgeon with subspecialty expertise in hip and knee replacement surgery, as well as the management of benign and malignant bone and soft tissue tumours. He practices across leading private and public hospitals, including North Shore Private and RPA, as well as the Children's Hospital Network, and as head of the New South Wales Sarcoma Unit, plays a key role in multidisciplinary sarcoma care at Royal Prince Alfred Hospital. He completed his medical degree with honours at the University of New South Wales, followed by orthopaedic surgical training in Sydney. He undertook advanced subspecialty fellowships in orthopaedic oncology and complex reconstruction in Sydney, Toronto, Basel and Vienna. Dr. Boyle is a Fellow of the Australian Orthopaedic Association and is current Sarcoma Subspeciality President. In addition to his clinical work, Dr. Boyle is Medical Director of the New South Wales Bone Bank, Associate Professor, University of Notre Dame, and Senior Lecturer at the University of Sydney. He also holds Australian and international research and leadership roles, including within ISOLS, APM STS and BOOM. Chair of the New South Wales Sarcoma Multidisciplinary Team, ANZA Board Director, and he is an inaugural member of the CRBF Medical Advisory Board. Richard is our guest here on This Medical Life podcast. Richard, welcome.
Thank you. Thanks for having me.
Richard, how do you approach a patient who's been diagnosed with a soft tissue sarcoma?
That's a very general, broad, interesting question. But I guess the first thing to say is often it's a very worrying, confronting diagnosis, or perhaps potential diagnosis that they've been informed of. And so probably the first thing to do is just to allay their concerns and just to find out exactly what it is that they know about soft tissue sarcoma and what it is that they think is going to be happening next.
So when we're looking at sarcomas, we know we're putting this under these episodes under a broad banner, and there's 70 different subtypes. Is there an easy way that you manage dealing with all the different subclassifications and subtypes?
I guess from a clinician perspective, yes, and a diagnostic perspective, yes. But when it comes down to the patient, not really, in that it is too confusing to try to explain all the different subtypes. And as an overarching rule, we approach them as though they are either down the very aggressive, malignant end of the spectrum or down the more, well, some of them are benign, but let's say if we're just dealing with the malignant end of the spectrum, some of them can be less worrying, so to speak.
Just on the benign issue, is there many that will come your way that are benign but still need extra management? It's a really difficult thing for extrication or surgery?
Yes, yeah, definitely. And so there's a significant proportion of our practice that is exactly the case. And in fact, one of the tricky areas of our practice is actually some cases that do not actually need anything doing, but the patients have been told either through a query on a MRI report or a query from the GP that it could be, and we need to explain them back to the fact that no, they either don't need a biopsy or they don't need further management. That can be a tricky part of our practice.
So looking at then sarcomas and malignancy, what are the risk factors for people developing sarcomas?
It's not really known. The many instances we will just say this is unfortunately just bad luck. The usual things of smoking and exposure to radiation or those sorts of things, yes, will absolutely increase your risk. And there's a definite association if you've had prior treatment with radiotherapy for something else, for example, breast cancer or prostate cancer. Realistically, often there are many cases where we do not know what the cause has been.
Looking at the presentations, again, we know this is under a broad banner, but is there any common or really classic presentations of sarcomas?
The worrying presentation would be a firm lump that is deep or tethered to muscle, that you can sort of feel that it seems to be associated with the muscle, that seems to be growing rapidly. They're not always painful, but sometimes, and obviously if there is pain associated, then that's another factor. But often it's just a deep lump that is growing quickly.
Clearly looking at your skeletal muscle, is there any fatty lesions that concern where you sit there and just go, this is actually a really rapidly growing one, or they're not superficial, tend to be okay, whereas deep not?
Yeah, so superficial fatty lesions as a general rule are not so worrying, but yes, they can be, but it's that firmness. So whether it's superficial or deep, yes, superficial and firm and growing is still worrying as well. There was a great campaign that was run in England a long time back. Basically, the size of a golf ball is worrying, and if it's firm, that's worrying. Go and see your GP, and then the GP should refer them on to a specialist centre.
Are there any red flags for you with seeing a patient and actually saying, oh, that's something that's really needs to be dealt with straight away, that either a general practitioner may have referred through, or a question that you ask for patients?
Yeah, so those previous points, obviously, but then also the imaging characteristics are what concern us. And so sometimes patients will have just had an ultrasound done, and that's fine. And if the GP then refers it to us, then more often than not, we'll order an MRI scan. And then the features on the MRI scan are what we look at closely that are worrying. So, we're starting to get into the realm of why multidisciplinary approach to soft tissue sarcomas is super, super important. But just to step back a little bit, if someone came along to me with a lump, as I've described there, then I would send them for an MRI scan. Obviously, if I'm worried enough about it, to think that it's going to need a biopsy, then the first steps are usually MRI scan and or PET scan as well, which is a whole body activity scan.
You've mentioned the scans there. Is this useful for you to request or the multidisciplinary team to request, or is this something that a GP who is working someone up potentially for a sarcoma to request before they actually send them to you guys?
It's probably a better practice for us to do it, in that we have access to booking time slots for those sorts of scans relatively quickly. For example, at RPA, we're very fortunate. We've got an excellent service there. But even for MRI scans, if they're urgent, then we're more likely going to be able to organise for that more quickly than a GP may. And then the other little quirk of the Medicare system is that the rebate for an MRI scan is a bit better if you've had it ordered from a specialist.
Do many patients present with advanced disease for soft tissue sarcomas?
They can, yeah. And so hence when they come to see us, and you're talking about here staging, and so there's all sorts of terminology, as you know, that's used in this sort of realm, and often patients can get a bit confused by all of the different terminologies. And so that's something else I'll say up front is, look, just stop me, and if I'm using medical jargon, then just ask. So staging, which is essentially to find out if it has spread, you are correct. And those scans include chest CT scan and then that PET scan. And so if someone presents to us with spots elsewhere, then that's more concerning in terms of prognosis. And you're going to your question specifically, look, are we seeing more people with advanced disease? Not necessarily, but it comes in waves.
We've talked about imaging. Are there any useful blood tests or any useful genetics or anything that's just less invasive, so to speak? I mean, though imaging is not invasive, but is there any blood tests that are useful for people to be considered with soft tissue sarcomas?
Not yet. And this is the interesting thing about soft tissue sarcomas, is that they're different to carcinomas, different to prostate, different to breast, different to organs that produce substances. And so, prostate's a really good example there. If you've got a prostate cancer and it's producing PSA, then you can have that blood test. The problem is your muscles or your fat doesn't produce anything. So it's not as though there is the possibility to go and check your fat tumor level because it doesn't exist. But the future though is this fantastic research that's going into what's called liquid biopsy, which is basically looking for foreign elements of DNA circulating in your body, DNA, RNA, whatever it is. You can tell I'm an orthopaedic surgeon rather than speaking about all that fancy stuff. But I'm super excited. Imagine not needing to send someone for a chest CT and a PET scan every 3 months. That'd be brilliant. And I think that is the future, but not yet. We're not there yet.
I just want to pause as the layperson here, because in the earlier question when Travis asked, are there any risk factors, what do we know? And you said, look, humbly, we don't really know that much at the moment. But there was excitement in the way you were talking about the liquid biopsy there. Is this one of those areas of medicine where you feel we're on the cusp of emerging from the shadows to have greater visibility and clarity than we have in the past?
I'll let you know, quite honestly, I'm an optimist, and so I'm going to answer yes to your question. There is great hope, and I think it will come. I think it will come, and not just in sarcoma. I think there's all sorts of areas now that are looking at, those circulating things, and I think that comes back to the days of COVID. Was there something good that came out of COVID? Well, these sorts of rapid tests for looking at little pieces of COVID floating around. I was going to say in the sewage system, but that's probably not appropriate for this podcast.
Oh, no, it often is. Yeah.
Now, looking at in planning these episodes with Fiona, she mentioned something I hadn't heard before, which is something we will discuss with her, but also wanted to discuss with you, something called a whoops lesion. Can you tell us what a whoops lesion is and just discuss about it?
Yeah, sure. So this is, I guess, the one of the disappointing areas in cancer medicine, if you like, but more in the surgical realm, where a lesion, and perhaps the step back from whoops is to use the term an inadvertent removal or inadvertent procedure has been performed where it was not known to have been a sarcoma. And the problem is that then the further management is compromised. And sometimes the worst case scenario is that the tumour may well have been spread and therefore will actually affect the patient's prognosis. So it's actually a very serious topic and something that we're worried about. And we've got a brilliant project running at the moment looking at the incidence of whoops lesions and the incidence of inappropriate biopsies or procedures that have occurred done by other medical practitioners that were not aware that they were either dealing with a sarcoma or were not aware of the correct process to approach a sarcoma or a lump or a lesion that could be a sarcoma. So that falls down to us with better education and better practice and getting out there into GPs, radiology practices and so forth to just make sure that knowledge of sarcoma is increased. And so this sort of podcast is brilliant so that then more people become aware of sarcoma, because I don't know, I mean, whether I can ask our layperson on the panel, as you've termed yourself there, mate.
Yes.
Before you started this process, did you know what a sarcoma was?
I had a vague awareness of the term, and that's where it stops.
Yeah.
Yeah.
Yep. And I remember learning at med school that sarcoma was a terrible diagnosis and everyone died. So you wouldn't want to ever become a sarcoma practitioner. And here I am, sarcoma is my practice.
And just a pigeon pair with Travis's question about these whoops lesions or inadvertent surgical procedures. Are they common? Are they rare?
Unfortunately, more common than we had hoped. And the other disappointing thing is that they've been known of for many, many years, and we've published on it in the past, and many centres around the world have published on it, and they are still occurring. And so there's obviously a gap in education.
Is there any rule of thumb you can give us as to, for doctors listening, as to what might be something that says maybe I shouldn't go forward and biopsy this or excise this? Is there any useful rules, I guess, that you could sort of try and avoid this for doctors?
Yeah, definitely. So one of the rules we go by, and I sort of touched on it earlier, is if you think a lesion warrants a biopsy, then it definitely warrants an MRI scan first. And if it's warranted an MRI scan, you then need to think, should I also be getting a PET scan? And if you've said yes to both of the above, then you should be thinking, should I get an opinion from a tumour centre before I do anything further here? And that includes not just biopsy, but also surgical resections. And you might think that it occurs in small country centres where, the patient will come in and say, can't you just whip it out, doc? Come on, I've got to, get out and, get the weed off the crop next week, just sort me out. And I'm sure that occurs. But unfortunately, it also happens in, you might have heard of this little suburb called Glebe, which is next door to Newtown. And what do you know, RPA is the next suburb down the street, and so it happens everywhere. So it's not just an isolated thing. And this is why we're running this research, in that we're trying to find patterns, but at the moment we can't really pin it down other than to say that we need to make sure that GPs and general surgeons and people that aren't always operating in the sarcoma sphere, that they just have a think about it. And so hence my sort of little stepwise thinking above there. And then once you've got that advice from the sarcoma centre or from the tumour centre, then often we will say, that looks very bland, or that looks very small, or that's very superficial. Take it out using a longitudinal incision, so that then if it does surprisingly come back as something unexpected, then the patient has not been compromised by that procedure. The problem is when we have patients come back and they've had big incisions performed with skin removal, and then they've come back and the margins are positive on a tumour, we then have to perform sometimes at worst an amputation if the limb cannot be salvaged because that procedure has been done wrongly.
So you actually will get referrals from doctors saying, look, we've got a lesion here. Can you please essentially triage it for us to make sure it's fine to remove? Right.
Correct. So we triage anywhere from 80 to 100 cases a month. And of those cases, we will see probably in the order of 30 to 40.
Right.
The guys in Adelaide are fantastic. They do the same thing. So just to put a shout out to the guys in Adelaide, Luke Johnson and Jake Jagiello. I don't know if this is just going to Adelaide or we're going national.
Oh, we go national here in Adelaide. We go everywhere.
And branch international into Asia and everywhere. So it's all good fun.
Yeah. Oh, brilliant. Okay. Well, I should name all of the guys in Australia then.
Yeah, we've got half an hour. Let's do it.
Yeah. Yeah, but certainly. So, well, on that point then, if a practitioner does not know where their local sarcoma centre is, then jump onto the Australia-New Zealand Sarcoma Association website and find out where that centre is and get on the blower. And look, I can speak for all of the sarcoma surgeons in Australia. They would much prefer to get a phone call before a whoops procedure is performed.
Just on patients being referred to you, what information do you like to have when the first patient comes in to see you? Not necessarily just about whoops lesion, but just a patient being referred to you who is either has or is suspected to have sarcoma. What do you like the doctor to include in that information and scans or everything?
Yeah, so it's helpful, simple things, age and demographics is obviously important. How long the lesion has been there and what symptoms they have, do they have tingling in the nerve below where the lump is, that sort of thing. Did they notice it on their own, or was it picked up at a massage at the resort when they were away in January? That's a strangely common occurrence. People are not aware of their lump, and the physio or the masseuse will say, oh, you've got a big knot in your hamstring. I don't think it's a knot. You should get your doctor to have a look at that, and patients will say, yeah, I had no idea I had it. The incidental finding is not an uncommon thing, especially more, I guess, when we're talking about adolescent and young adult type sarcomas, which is sort of another realm, maybe beyond the scope of this particular podcast. But it's not uncommon for people to have a knock at footy, come on in, have an x-ray done, and what do you know, there's something unusual on their x-ray, and then we have to take it from there. But the nastier tumours, generally, patients will be aware of a lump and pain. So those factors are good. Simple examination would be helpful, and then a GP ordering an ultrasound and or an x-ray is often helpful. And as I say, we're then happy to take it from there and run with an MRI and or a PET scan if that's appropriate.
Some of the questions patients ask you, is there some common, it's always hard, but is there some common questions patients ask when they're seeing you?
With big surgery, then they're often interested in what loss of function they will end up with, and prognosis. And sometimes you can't give a definite indication. And I guess I was taught very early in my career by one of our fantastic medical oncologists, Professor Tattersall, who's no longer with us, unfortunately. But he used to say that he doesn't like giving percentages, but if you give patients a timeline, then that's often useful. And he said, if you think how long they're going to live, let's say they're going to live a year, then halve it and double it, and that's a good rough estimate. So if you think the prognosis is 12 months, tell them it's probably somewhere from 6 months to 2 years. And sometimes, we'll get a surprise and patients will live for longer than that. But also to quote another one of my great colleagues and mentors, Professor Paul Stalley, his approach was always, he used to say, we've got to play with a straight bat every time. It's not fair of us to withhold information from patients. And so if they're not going to survive for another 6 months, then they need to know that purely from a practical perspective of planning finances and so on and so forth, but also from obviously the emotional aspect and knowing that and letting know, loved ones and family members and so forth.
You did mention prognosis. What is the best measure of prognosis for patients with soft tissue sarcomas?
Your question earlier about if they present with known spread, then that's portends a poorer prognosis. The grade, we're talking about staging, so grade of the tumour, so how aggressive it is also a good indicator. And there's some really helpful online tools now that have been put together from a number of the units around the world looking at prognostic indicators, size and depth and grade and so forth, location, and they're all fed into a sort of a calculator that will give you an idea of prognosis. But it's hard because there are so many subtypes. Some do respond well to chemotherapy, some don't respond at all to chemotherapy, some respond better to radiotherapy, some don't. So it is very nuanced, and it does really come down to the tissue type. But as a rule, soft tissue sarcomas that are high grade are not great tumours to have. But the flip side is many patients do survive still, and so we give it a really good crack. And that's how I approach meeting patients for the first time. I'll say to them, you're up for a really hard, tough fight here, but we're going to fight with you, and then we're going to keep a really close eye on you with, post-operative surveillance and monitoring and so forth. So there's no point being pessimistic and morose, from the outset. If a patient doesn't have, that positive stimulus right from the word go, then they're going to find the journey much, much harder.
Richard, I've picked up, even as a layperson, a number of things, including before my next annual GP visit, I'm going to book in for a full body massage.
Yes.
But just to close off, do you have any final thoughts or advice for doctors and even patients about soft tissue sarcomas?
I guess just don't be complacent about it. Look into it early and investigate it just with simple measures. As I say, an ultrasound is not always useful, and we don't actually use ultrasounds beyond that first presentation necessarily, but it might just help to give an indicator that further investigation is required. And then also plain radiology, an X-ray is a very easy tool, looking for simple little things like calcification within a lump, or if the bone is involved, and obviously, now putting on my bone sarcoma hat, that's a very useful investigation up front. But yeah, if something's changing and something's and you're worried about it, then, again, giving a plug for all of my colleagues around the country, get on the phone and have it looked at early, and have it looked at by the professionals early. If someone comes along to me and they've hurt their knee playing footy and they've torn their ACL, I'm not going to sit on it and go, oh, that should be okay. I'm flicking it to my sports knee mates. I'm not the guy to be asking advice about, cruciate ligament surgery by any means. And so the flip side is absolutely true. More than happy to have the referrals come through. And the value of our service here at RPA is that we've got the systems in place. We've got some fantastic CNCs that are working with us now. We run our MDT every Friday, to which Fiona attends as well. And so you've got a lot of professionals in the room, all looking at these cases, all giving their opinion, and then you can be reassured with whatever advice comes back.
I'll also note that link you referred to earlier, we'll put in the show notes so it's easy for people to find. Associate Professor Dr. Richard Boyle, thank you very much for joining us on This Medical Life.
Thanks, guys.
Professor Fiona McLean is a clinical professor in the Department of Clinical Medicine, Faculty of Medicine and Health Sciences, Macquarie University. She's authored more than 100 peer-reviewed papers, 2 chapters of Sternberg's Diagnostic Surgical Pathology, and 1 chapter of Histology for Pathologists. Professor McLean is a previous president of the Australasian Division of the International Academy of Pathology, with interest in urogenital and musculoskeletal pathology. Fiona's a regular guest on This Medical Life podcast. Fiona, welcome back.
Oh, thank you for having me. I love being a regular guest. That's a nice thing to be.
Good, because we just underlined your name in our book now, so you are going to continue being one. Fiona, let's start. How difficult is it to diagnose a sarcoma?
Well, from a pathologist's perspective, I think I've used this analogy before. When we actually diagnose things, it's all visual recognition of patterns. I'm not like a machine where you put blood into it and you're asking for a calcium level and this machine spits out this calcium level. It depends really on what I've seen before. So how many cases I've seen and how well I recognise particular patterns. So it's like you take me to the art gallery and you show me a bunch of Van Goghs and a bunch of Monets and you say, what's this one that you've never seen before? Is it a Van Gogh or is it a Monet? And, this is how I work. This is what I do each day. I have, an eye for detail, and I like to try and find patterns within things that will actually help me classify things. So the problem with sarcomas is that they're quite impactful tumours. They often occur in younger people, but they only represent about 1% of adult malignancies. And they're quite a subspecialised group of tumours, and there's a wide range of them. There's sort of more than 77 in our, the book we use to classify everything. So there's quite a number of them, and some of them are so rare. In 20 years of work, I might have seen one once, and I do this sort of work. So it's very hard if you're a general pathologist, if you're doing a bit of this and a bit of that, and, you come up against a sarcoma, you may never have seen this particular one before. So trying to recognise a pattern you've never seen before is quite challenging. And then the other thing is nowadays we do use other tests to help us support our diagnoses. And some of those tests are only available in centres where we actually do a lot of sarcoma because they cost a bit of money to set up and to run. We will, sort of batch them in particular parts of the world and in particular centres. And so, if you're working somewhere in a more sort of remote location or in a smaller hospital, you might not even have access to some of the tests that I rely upon to actually, put that final nail in my diagnosis to be sort of absolutely robust in my diagnosis. So these are the reasons why it's tricky. And in fact, we just did a review. I'm part of the Australian New Zealand Sarcoma Association, or ANZA, and we've been doing reviews for clinicians and for GPs to help them understand how best to treat, manage, identify sarcoma. And one of the things we reviewed recently, which was published just this year, was about whether you should get a second opinion when a sarcoma has been diagnosed. And our review really basically summarised that there are quite a number of times where the final diagnosis maybe isn't quite there, and it's really important these days of individualised medicine that we do have the right final diagnosis to be able to give the right treatment. And so this can be, sort of 20% of cases even historically may not have actually been completely, formally diagnosed into the right subtype. So it really is quite important that these patients actually have access to a sarcoma service with a multidisciplinary meeting. And so that's what we've advocated. We've said that all suspected sarcoma cases should be referred to a specialist sarcoma unit so that the correct diagnosis and treatment can be given. They could go home and be treated in their local area potentially, but the advice from the sarcoma unit is very important. And actually, one of the other things, a paper came out last year from one of my colleagues at the Mayo, and he only does sarcoma. That's his whole type of work. So he's very experienced in this field. And the name of his paper was "I Can't Keep Up." And it's because there's so many new things we're finding all the time about these tumours, very individualised kind of molecular changes and that type of thing. And things are coming out each week in the literature. So it's actually very hard, even for those specialists in the field, to keep up. And I guess one of the other things that comes out of that too is it's very time consuming because you're actually trying to find the correct exact match for this tumour. And I do rely on my colleagues a lot. We go to a multidisciplinary meeting which has, radiologists, pathologists, surgeons, oncologists, radiation oncologists and nursing and other staff. And this meeting that we have is every week on a Friday and it goes all afternoon. And a lot of other multidisciplinary meetings, we just go and discuss what's going to happen to the patient. There's 10 minutes per patient and we talk about, this patient's going to have this or that. But at this meeting, it's more a diagnostic working meeting where we all sit around together. And most of the MDTs I go to have like one pathologist. Well, there's about 6 that attend this meeting because we all want to be in agreement when we make these diagnoses. And so that's why from a patient's perspective, it might sound like we're taking a really long time with their diagnosis, but it's because we actually need to get everything right. We need to have all our, T's crossed and I's dotted, and that's why it takes so long, because we're actually really trying to make it, the best diagnosis, most accurate diagnosis for the patient.
When we're looking at sarcomas, particularly soft tissue sarcomas, like the prefix tells us essentially where it's from. So you've got liposarcoma, leiomyo, rhabdo, angio. Is the tissue of origin for a sarcoma clinically significant?
Yes, because when we think about sarcoma, it's actually a really big, we use the term sarcoma, and that just means a tumour arising from the mesenchyme, which is any of those supporting structures. So not the cells that make a carcinoma. So, not a like a lung cancer or a breast cancer, because they are all arising from epithelial cells. We're talking about all of the supporting structures, so bone, the soft tissue structures, the vessels, the fat, the muscles, all of those sorts of things. But if you think about it, you're kind of comparing sarcoma, which is like a massive title, like a huge bag, to carcinomas. When you might have done a podcast on breast cancer, right? You're not just doing a podcast on carcinoma, which is a whole family. You're doing a podcast on, one particular cancer in that group. What we're doing today is a podcast on sarcoma, which is like doing a podcast on carcinoma, like calling it all the same thing. So you've got to think about, we say sarcoma as a title, but it's actually the overall title. It does really matter what type of sarcoma you've got, because they do respond differently, because they're all different types of tumours. So in our sort of classification, we have, as you mentioned, we might call something adipocytic, like from fat, fibroblastic or myofibroblastic, which are those, fibrous cells, vascular. We even have a category for pericytic, which means the cells around blood vessels, smooth muscle, skeletal muscle, peripheral nerve sheath tumours, which are the things that are attached to the outside of the nerves. But then we've also got a whole bunch of tumours that we actually call tumours of uncertain differentiation. So we don't even know where they come from, like what cell type they've arisen from. And one of the more common sarcomas we have, you might have heard of, is synovial sarcoma. It tends to affect younger people. And we use the term synovial sarcoma, and most people think it comes from the synovium, which is the lining of joints, right? Well, it doesn't. So back in the day when they were first naming this tumour, they had thought that that's where it had arisen from, so they called it synovial sarcoma. It's a little bit like the koala bear. We all know that's not actually a bear, that's a marsupial, but we still call it a koala bear. And so just for convenience and the fact that everybody knows what we're talking about and we're all on the same page, we still use the term synovial sarcoma, but it's completely a misnomer. It does not arise from the synovium. So we have this bunch of tumours that have uncertain differentiation. And then we have a subset of tumours as well where they're so aggressive and so high grade, they're so different from the normal tissue that they've arisen from. So when I do my pattern recognition, I'm trying to recognise that normal tissue. They're so different that I can't, when I look down the microscope, make head nor tail of what it's actually come from. It just looks so bad and so aggressive. And then I might go and do my extra testing that I do to try and work out what type of tumour it is. And some of them are so aggressive that they've actually lost all of their features even when I do that extra testing. So I might do some immunoperoxidase stains, or I might do some molecular testing, and I still might not find the actual type of cell that it's arisen from. And then I have to just diagnose what's called an undifferentiated pleomorphic sarcoma, which, it's got to have arisen from somewhere, but I just don't know where it comes from. It's a little bit like baby pigeons. I don't know where they go. I don't know where pigeons come from. I've only ever seen adult pigeons. I've never seen a baby pigeon. So it's a sort of like, to me, the undifferentiated pleomorphic sarcoma, or the UPS, is like the pigeon of the world, because, I've just never seen where it's actually come from. So I can't really tell.
Now, are there any useful guidelines for when diagnosing sarcomas?
Guidelines. Yes. So I think we tend to, want to sort of put things into patterns. So when I look at something, although I know that they've arisen from different families of tumours, I actually start looking at the pattern that I can see. So I'm trying to actually go, okay, morphologically, because the H&E, the hematoxylin and eosin stain, it's kind of like the basic stain in histopathology. It's that pink and purple stain that people see at medical school that everyone starts with. And it's still actually the king in my work, right? It's still actually the most important thing. And everything else that I do is sort of tailored depending on what I see down the microscope on that basic H&E to start with. And so what we tend to do in sarcoma is a lot of pattern recognition based on the actual shape of the cell. So I have cell types, and then I almost have like a tree in my mind. If a cell looks like this type of cell, then it's probably going to be one of these types of tumours, and I might then do a panel of immunoperoxidase stains to try and work it out. Or if it looks like this, I'll do a different panel. So I tailor everything depending on what it actually looks like on that basic H&E stain. So it could be a spindle cell. It's quite a common pattern, and that's called a spindle for like the spindles in wool, like in when they sort of wind wool onto a spinning wheel. There's a spindle, which is a sort of almost like a flat, elongated football. Like it has that kind of, it's sort of plump in the middle and tapers off on both ends. So that's a spindle cell. That's a very common pattern that we see. We see an epithelioid pattern, which means it looks like epithelium, which is like what we see in carcinomas. So it might look like a cell that looks a bit like breast cancer or melanoma or something. And then there's a really common pattern we see, which is called a small round blue cell tumour. So we'll often have a box, which is just called small round blue cell tumour. And there's a whole bunch of tumours in that box that all come from all different families, but I can usually recognise them, as to being part of that box. And so therefore I have a panel of stains that I will do to try and help myself work out a bit further. I don't know whether on a previous podcast I've said this before, but to me, looking at these things, it's trying to put them into a family, and it's a little bit like looking at the Kardashians. With the Kardashians, I can never tell which one's which, right? Like I can't tell one Kardashian from another, and to be frank, I don't actually know what they do. But they're all kind of, Kardashians together, and I can recognise them as being part of one family. Right, there are things that are Kardashian-like about them, and I can say, well, that is a Kardashian. Can't tell you which one, so I might need to go and do some stains to try and work out which Kardashian it actually is. But I can tell you it's a Kardashian, and so that's kind of how I do my job. It's all to do with Kardashians.
And they're probably as unwanted in the human body as well.
I probably wouldn't want one in my body. Yeah, no. You're probably right about that.
We're looking at then the inherited syndromes. How useful is it for you to know about that for sarcomas?
Yeah, so, people with inherited syndromes do have a higher risk of sarcoma, but to be frank, most of the people who actually get sarcoma don't have an inherited syndrome. So, yes, it's important, for me to be aware of that, and I do appreciate it when somebody actually gives me that information. It's always very hard when you haven't got that information in the first place and it sort of, drops later on. But it is actually very helpful, if they do have that. So in less than 10% of cases of sarcoma, there is some sort of link that we can identify. So, a genetic predisposition or some environmental factor. Actually, history of radiotherapy is actually one of the things we really look for. And that might be 5% of tumours, and that can occur 10 years down the track from the radiotherapy. So that's actually really important to know about. And in regards to those genetic predispositions, some of them even predispose people to having these radiotherapy-associated sarcomas. So if they've got a predisposition that's caused a cancer of some other type, they go on and have radiotherapy, then they're actually at much greater risk of having one of these radiotherapy-associated sarcomas down the track. And those particular ones that we worry about, in particular with the radiotherapy, are germline mutations with the retinoblastoma gene, RB1, TP53, which is also called Li-Fraumeni syndrome, and neurofibromatosis, usually type 1. And they put people at risk of post-radiation sarcoma. For risks of untreated, not related to treatment sarcomas, Leaf-Raumeni, about half of those patients will actually develop malignant tumours by the age of 30, and about a third of those will actually be sarcomas. So that's actually quite an important group, but really it's a very small group of people. So most people who develop sarcoma don't actually have Leaf-Raumeni, of course. There are some other tumours that people are predisposed to. Desmoid fibromatosis, whilst not a malignant sarcoma, it is actually a tumour that keeps coming back and is sometimes a difficulty to deal with. And that can occur in patients with Gardner syndrome, which is a type of familial adenomatosis polypi, which is from the bowel, where you get lots of polyps in the bowel, which predispose you to bowel cancer. Well, it can also be associated with these deep fibromatosis tumours. And neurofibromatosis can predispose you to malignant tumours, as well as all those little benign tumours that they get, so that's sort of like the elephant man syndrome. But what can happen is a small proportion of those tumours can then develop malignancy. So we actually surveil those patients and watch those patients carefully just to make sure they don't have a tumour that develops within one of those benign tumours.
A lesion I hadn't come across before until we discussed soft tissue tumours is the Whoops lesion. Now, I hadn't heard of that before, and I had to go and look it up, and then I didn't realise it wasn't an actual diagnosis. This is more of a sort of a term that is used probably in MDMs, I'm guessing. Can you tell us about the Whoops lesion from a pathology perspective?
Yeah, so Whoops lesions are actually, unfortunately, not that uncommon. So what happens, sometimes it's a younger person who might develop a sarcoma, and so the assumption is made that it's going to be something benign, because young people often don't get sort of, malignant tumours as much as sort of older people. And then somebody will have a go at doing a biopsy or an excisional biopsy where they think they're taking it out with a very narrow margin. And often on the clinical notes, it comes sent in as a cyst or maybe a lipoma or something that it just didn't seem quite right. It's usually with a question mark next to it. So the clinician often thinks, it could be a cyst, but it's very strange for a cyst. It's a bit weird, and then has a go taking it out anyway. And I think that the flag should be that this isn't really quite right, it's not quite what I expect. And if it's sort of, greater than 2 centimetres, we kind of say be a bit careful about, making a decision to take something out you're not sure about. And the problem is we get these lesions which are whoops. So the clinician's thinking cyst or something benign, and I look down the microscope and it's a high-grade sarcoma. And sometimes it's been cut through. So the problem is then that the planes, are not there, for the surgeon to go back and do a, re-excision in a sort of nice, clean manner. And then also there can be contamination. So if you're cutting through a tumour, it can contaminate the area so that you can contaminate different compartments. And then the surgeon really has quite a tricky next step as to how to sort of deal with this. And so this is a really big problem. You've got a young person who's got a sarcoma that could have been managed with a nice clean excision, with a nice margin by a sarcoma surgeon who has experience in this space, yet now they're having to manage something that's actually been cut into and potential for, contamination of adjacent structures and that type of thing. So we refer to those as Whoops lesions. It doesn't only happen when somebody tries to excise something. Sometimes it's just having a go at biopsying it and not planning the biopsy, so that they might actually do biopsies in different places rather than through one tract, which could be excised by the surgeon as well. So for a deeper lesion, you want to biopsy through the one sort of tract so that the surgeon can go and excise that whole tract out with a nice clear margin, so that's all gone as well. But if you're coming at it from different angles and making different tracts, and that can be a problem too. So I would expect that this would be a good question for the surgeon when you speak with him as well. But it's one of the things we don't, like to see. And we like to encourage people to refer or even just get advice from a sarcoma unit if they're not sure about how to manage something. We're quite happy to sort of help with those sorts of things.
So as the layperson on this podcast, when you say whoops lesion, we're really talking WHOOPS, as in, ooh, maybe I shouldn't have done that.
Yes, and the thing is, you want to get on and manage something, can fix something, I mean, that's, I understand the sentiment, and it's often a busy clinic, and sometimes people are sort of remote from, city centres, or, I completely understand why this occurs. It's, not anyone trying to, do something that's not going to be helpful. But the problem is sometimes, and in fact, we do see this more often than we really should. And so I've actually got a medical student working with me right now, and we're going back looking at all the whoops lesions and trying to characterise, what sort of things actually prompted a whoops in the first place, like what was the mistake, like what was the thing thought to be. And then, what was the context? So, what sort of person would send where were they working, and what was their sort of background, just to sort of help with a bit of education to say, well, this is the thing that we really, struggle with, and maybe a pause before acting, or even a thought to sort of think about, asking for advice or referring on.
That's going to be invaluable. To go back to your earlier analogy of the art gallery, what you're really trying to do is say, look, this is actually probably an Andy Warhol. This is not a Monet, etc. So let's do this one differently, or pause.
Yes, absolutely, absolutely. And I think that's exactly right. Like, I think medicine really is an art, and it's appreciating art. And I think it's not just in pathology that holds true. It's in, with our colleagues across the entire spectrum of doctors. And sometimes things just don't fit your paradigm that you're used to. If it doesn't fit, maybe pause before you act.
Now, these are incredibly rare lesions, and I mean that as of coming from a pathologist to look at some of these things under the microscope. I used to have to go back to libraries that people collected, and you just wouldn't see the lesions. So doctors may not have even read about sarcoma, like a sarcoma report, and then they get one on their desk. Is there any prognostic signs of a sarcoma report that is really useful for doctors who are reading who may not have read a sarcoma report?
Yeah, indeed. I try and make my report useful, so I do try and help out with things in the report. So the things that we're actually looking for that help us with prognosis is the grade and the stage. So the grade are features within the tumour which give intrinsic signs of how aggressive a tumour might be. So that will help you with, its aggressiveness. The stage is how extensive it is already, so that will help with prognosis as well. So for stage, we tend to use the AJCC in Australia, and that's a staging system that's easily available online. For grade, most of us use a French grading system, which is called the FNCLCC system, and they're all words in French, so I'm not going to try and pronounce them because I'll only embarrass myself. But basically, how I was saying, you most of your podcasts are specific to a particular type of carcinoma, and we're talking about a big bucket here called sarcoma. The problem is, you're saying, well, give me a grading system that actually applies to every type of tumour that comes from, blood vessels, muscle, whatever. Give me one grading system that grades it all. It's like the one ring that, rules them all. And I guess maybe I can kind of be a little bit political here and say sarcoma is not a monoculture. There's a whole range of different tumour types in there. So we do use this one grading system, but that comes with some kind of caveats because there is such a wide range of, of tumour within that. And we give it a grade from 1 to 3, and 1 is low grade, 2 is intermediate, and 3 is high. And just like most things we grade, usually grade 1 to 3. But we look at 3 different things when we're actually grading it. So we give a score for how much it actually resembles the normal tissue. So that's called tumour differentiation. We look for how rapidly the cells are dividing. So something that grows fast is usually worse. So we look for mitoses, which actually tell us how fast the cell is dividing. And then we look at necrosis. So tumours that grow really fast outgrow their blood supply. And so then they die. Those bits die because they can't, keep up. The blood supply doesn't keep up with the tumour growth. So you see necrosis. So they're the 3 things we look at. How much does it look like the normal tissue? How fast is it dividing? Like how many mitoses are there? How fast is it growing? And how much is it outgrowing its blood supply? So how much necrosis is there? Some different types of tumours we don't use this grading for, but it is the most common grading that we use. in a report, you want to be looking for those sorts of things, but you also want to be looking for, well, what actually is the tumour? What type of tumour? Because there's a range of malignancies within the malignant bucket of sarcoma, and 3/4 are highly malignant, but 1/4 are actually quite indolent and behave, in a much sort of lower grade manner. So you really want to read your report as to what the type of tumour is as well. And things like whether the margins are positive or not, if there's any tumour left behind, if there's been tumour within a vessel like lymphovascular invasion or around a nerve, perineural invasion, they're going to be quite important to indicate how a patient is likely to progress. And then in sarcoma, rather than just benign and malignant, we actually have this interesting thing which is called intermediate. So we actually have this concept of intermediate tumours which aren't really present in other tumour groups. And so we use that group for tumours that very rarely metastasise but might. So we can't say that it's completely benign because maybe 20 years down the track this patient might have a metastasis. Sarcomas are a bit difficult because they are things that pop up later, much later sometimes. And it's not unusual for me to have a case that was 30 years ago, a patient had something, and they forget about it, because it happened 30 years ago. So they don't tell their new GP, most people don't have the same GP that they had when they were 25, right? When they're sort of 55, right? And so they forget to mention to their GP at 55 when they have a lump that they had this thing back at 25 because nobody really worried about it and it seemed okay and it went away and it was dealt with. So we have these rarely metastasising things or late metastasising things that are of intermediate grade. And then we have things also that are locally aggressive. So that desmoid tumour that I spoke about before, although that's not considered to be malignant, because it kind of locally recurs and can be a problem, we've kind of put that into this intermediate group. That's all kind of part of the things that we would look for. So the type of tumour, the grade and the stage are really helpful.
Do you use many immunohistochemistry or molecular genetics with diagnosis?
Oh, baby. Yes. So I think my lab manager hates me because I cost a lot of money. I kind of feel like, and I don't know if I've used this analogy on a previous podcast, but when they had that $2 milk down the back of the supermarket and you have to go all the way down to the back of the supermarket to find it, but on the way to the back of the supermarket in your little basket you seem to accumulate the Kit Kats and the chips and everything that you walk past on the way, like out of the corner of your eye you see this thing that you really shouldn't buy but you go, oh yes, I'll have that as well, thanks. And then by the time you get to the cash register, it's not just the $2 of milk, you've spent $20. So I feel like I'm the $2 milk down the back of the supermarket. I actually cost the lab quite a bit of money when I'm working up a sarcoma. And in fact, the amount of money that we are allowed to bill for a sarcoma is less than I would cost, right? So the tests that I do are going to cost us more to do than we will get rebated or paid for because they just need to be done. So we have to do them to work the tumour up. And hopefully we'll make the money back on other things that clinician might send, blood tests and stuff like that, where we are going to make a little profit margin. But certainly on sarcoma, because of the things I order, I'm actually, losing money on most cases. But it's important to work them out. So we have to sort of work them up properly. I'm not only going to go halfway and go, oh, we've run out of money, so therefore you can't have your diagnosis. So yes, I order quite a few stains, I might say, but they are tailored. So I don't just go in and go, okay, we've got over 150 stains that we can do in our lab. I'm not just going to go in and order all of those and just randomly hope that, we'll be able to work out what this tumour is. I do remember when I was a junior doctor and I went to ask a very senior pathologist about whether I should do pathology or something else, and his advice was, well, there's this extra testing coming in now, it might replace us, right? So everybody might actually just order all these immunoperoxidase stains and then they'll be able to work out, what a tumour is, and they won't need a pathologist because the immunoperoxidase stains will tell them. Well, actually, they overlap quite a bit, and it's really important that you actually choose the right stains to do in the first place. then the stains are actually hard to interpret. They're not necessarily just yes/no answers. Sometimes it's, how much is staining, what part of the cell is staining, what the nature of the staining is it granular, is it membrane? So I have to put all of those things into perspective and kind of work it out. But you know how I was talking about looking at those patterns and making a tree in my mind and thinking, is it a spindle cell, small round blue cell? I have certain stains that I would order, like a panel of stains that helps me rule in or rule out something. Now, sometimes sarcomas can look like non-sarcomas, so I have to rule out those non-sarcomas, right? So it could be melanoma. In Australia, melanoma is quite a common disease, and it can look like practically anything. So I need to make sure it's not a melanoma. So I need to rule out a bunch of things, but melanoma, other types of carcinoma, mesothelioma, germ cell tumours, or even some hematological tumours can look like sarcomas. So I need to rule those out. So I need to have some stains that say, okay, it's not that. Then I need to rule in particular sarcoma subtypes. So there are things that I need to look for to try and confirm my initial impression. And remember I talked about those undifferentiated pleomorphic sarcomas where I don't really even have an initial impression. I'm desperately trying to find some sort of lineage in those ones to try and work out where they've come from. So, before I started in pathology more than 20 years ago, we did only have limited immunoperoxidase stains, and they looked for sort of structural elements or cytoplasmic elements in cells. And so broadly, we would do this sort of stain called Vimentin, which might tell you that it was more likely to be a sarcoma than a carcinoma. That was such a non-specific stain, it really was almost like tea leaves, right? And so I don't remember the last time these days I've ordered a Vimentin. It's not something I currently order because it doesn't actually help me. But 20, 30 years ago, it would have been one of the first things you looked, for in regards to was it a sarcoma or not. So then what happened was we started to get, maybe 20 years ago, markers which were much more specific and useful for looking for cell lineage. So we have markers that help us work out whether it's actually skeletal muscle or whether it's a vascular tumour. But these still overlap a fair bit. They're not one marker that I know of is 100% specific for a particular entity. And then maybe in the last 10 years, we've had a bit of a shift. So we've gone from just lineage, like what type of cell it is, to actually looking for nuclear transcription factors. So there's an underlying molecular abnormality, where there's a nuclear transcriptions occurred, so that there's actually been a change in the product that the nucleus is making. And so basically you can identify that with the immunoperoxidase stain, and it's a lot more specific. None of them are 100%, but it's a lot more specific. So we can now look for particular things. So, I was talking about that synovial sarcoma. There's a particular immunoperoxidase stain I can now do that really does help me to know if it is really a synovial sarcoma or not, or one of the mimics. And then we also have some more stains now where we actually look for loss of expression, and that also helps to work out whether something's actually been turned off by the underlying molecular changes, and I can use that. And then there's also what we call companion diagnostics. So if there's a treatment that's actually useful for sarcoma, so sometimes we might use a TRK inhibitor, TRK, or an ALK inhibitor, I can now stain for those things as well and sort of get an indication as to whether those drugs might actually work in that patient. So these things are all very helpful, but still H&E is the king, and I'm still looking at the beginning with my H&E, trying to help work out, okay, what type of cell has this come from? What type of tumour are we looking at? What type of subtype?
Fenna, let's just go one step further. What role does molecular genetics play in diagnosing sarcomas?
Yeah, so molecular genetics is actually becoming more and more important in histopathology, in diagnosis, in general. But one of the fields where it's really, really kind of surged ahead is in sarcoma diagnosis. And whilst, I was saying that most cases we kind of look for our diagnosis on morphology and then, use the immunohistochemistry to confirm our suspicions, there are times when molecular testing is actually essential now, and that's things that are difficult to classify, and that could be because it's undifferentiated, so I can't tell down the microscope really what it is, or if it's just, one of those tumour types that's just a bit unusual, or, it's sort of fairly unique. We do have some what we call novel tumours in sarcoma which just don't, fit into any of those boxes, but might have an underlying molecular abnormality that we could actually then treat for. And then the other thing, obviously, if this is a deep tumour or something like that, they might only have been able to obtain a small sample. So actually having the molecular testing rather than exhausting the tissue doing a million immunoperoxidase stains would actually be the wiser route in that situation. Of course, none of these tests are standalone tests. You actually have to sort of weave them back into the tests that you've done in association with what your, original opinion was down the microscope. And we actually have a term for some of these tests, the results, which is promiscuity. So sometimes you'll actually get exactly the same test result, molecular result, for two completely different tumours. So just having a particular translocation does not mean it equals a particular tumour. Sometimes it does, but sometimes you've got to be careful because there is overlap. And so there are known subtypes that are actually very robust, and we can actually test them. So, we've been talking about synovial sarcoma a lot. There's an SS18 SSX translocation that they all virtually have. And so, you have that, and that pretty much helps you with that diagnosis. And then there's also another sort of situation. It's when the morphology can be challenging, to be sure. So one of the most common soft tissue tumours we get is called a lipoma, which is a benign tumour of fat, and lots of people get them. They can be quite superficial, and sometimes they can get traumatised. So a traumatised lipoma, which is like bundles of benign fat, if you kind of bang it around, the cells take on these changes that actually look like what we see in the malignant version, which is a liposarcoma or an atypical lipomatous tumour. And so down the microscope, a banged up looking lipoma can look like a liposarcoma. And then we go looking for molecular changes to help us understand whether it's actually the bad player or just the good guy that's been beaten up a bit, right? And so we look for what's called MDM2. We look for whether there's amplification. And we have a whole range of different ways of testing for our molecular genetics depending on what the actual abnormality is we're going for. So again, a little bit like the immunohistochemistry, we just don't throw 100 stains at something and try and work out what it is. You actually have to know what you're looking for, what molecular abnormality you're looking for, and then actually choose the correct testing modality. So again, for a general pathologist, that's actually really hard to know. And maybe that's the time also to refer on, because the government does rebate testing for sarcoma, which is great. This is something that's only happened since last year. You can have each sample tested for molecular genetics for sarcoma, but you only get the one test per sample. So you want to be able to make sure you're actually doing the right test. So sometimes for second opinion, I'll get things that maybe have had the wrong test ordered on them, and they've already lost then that Medicare rebate. So then the patient might have to pay out of pocket or something, like that, which is also a bit challenging for the patient. So it would be much better, if you don't know what test to order, maybe rather than having a go, again, another time to pause and just say, okay, maybe this is time to refer.
Again, I'm loving the terminology. As the layperson, I'd be saying to Trav, the subtitle for this episode is From Promiscuity to Whoopsie, but I know he's going to override me, so that won't be the case.
No, maybe not. No. Now, are there any useful resources for doctors or GPs or healthcare professionals about soft tissue sarcomas?
Yeah, there are. ANZA, as I mentioned earlier, has a great website. If you look at sarcoma.org.au, there's actually some good explanations, which are really good for patients as well. I was talking about those guidelines that we'd been working through over the last few years about identifying and treating sarcoma. Well, they're actually all available on that website, and they've gone through, we've spent quite a lot of time with different specialists involved reviewing, with a systematic analysis, all these different aspects of how you would do this. there's where to find a sarcoma team, where you might be able to identify one that you could reach out to if you need to, how to obtain a second opinion. There are links for patients for various other sarcoma groups with lots of explanations about what types of sarcoma mean and what different words that we're using, because it's a completely different language, I think, in sarcoma. So, for patients who are coming, up across this, it's actually very difficult to understand, exactly what's going on, because it's a different experience. It's a different tumour type from, those more common cancers that are often spoken about a lot more in the media and, people are aware of. And, it's often younger people, so it is hard because it's such a, confronting kind of disease to have to sort of deal with and understand. And, we have resources on there for support as well. There's a really good group of people who've experienced sarcoma who there's a, get together and actually discuss and support each other. And then, I think we all like to support each other too, as clinicians, because these are difficult diagnoses. And so, there's quite a collaborative kind of, group that works together in this. So, if you're having to treat somebody, there's, advice and support that you can get that way as well.
So Fiona, Travis will get all those links from you to put into the show notes to make it easy for people to find. Just in closing, for any doctors or patients who are standing at the edge of the gallery of sarcoma and they're about to enter this realm, what sort of final advice or thoughts do you have for them?
This is quite a rare tumour type, but it's really impactful, with often very significant outcomes in often younger people. And so the work is really important. The work you're doing in this space to support somebody through this is massive. And, people will often require extra support and to be aware of that. But, I think to feel that, you're not alone, they're not alone on the journey, you're not alone as the clinician. I think, we're often very collaborative, and I think that's really important, that everybody's actually here trying to support each other and support the patient. I think just to remember about the whoops lesions, pause before acting, and get advice if necessary, I think are the two, important things,
Professor Fiona McLean, thank you very much for returning to This Medical Life.
My pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.